This is an area that has been a lot of interest from my group. I will present some of the data in the literature, and at the end I'll present some of the studies that hasn't been published, but I think it's going to change the way we manage diabetes in the elderly. So the first question is, when you talk about diabetes in the elderly, is to define elderly. Right? What is elderly? I mean, to me, it's 10 years older than the oldest person in this audience. So maybe somewhere around, who knows, 70, 80. But if you look at it in the United States, we call elderly maybe with the definition of Medicare. But Medicare became available in the 40s because at that time life expectancy was just in the 50s, 60s. Now life expectancy has gone all the way to 78. So the World Health Organization defined in Africa more than 50. So I think that's the problem when you talk about diabetes in the elderly. But definitely this is an area of increased interest in the way that the population are going up significantly. This is the life expectancy in the United States. Went up from 1996, we were in these low 70s. Now we are in the high 70s, and for women it's going to be in the 80s very soon. And I went to the internet and looked at the United States and India, shown here in blue. I can project that. But your life expectancy, according to the internet, is 68 years. And going up, the life expectancy in India goes up by 5 years in a decade. So you are going to get as old as the other countries. So when you talk about diabetes, diabetes is a disease of the elderly. That's right. Although we see an increase of prevalence of type 2 diabetes in children and adolescents, it's still quite rare. The main group of people that develop diabetes are those who are going to be in the 40 to 60. That's when the peak of diabetes. That's when the ADA and every organization says screen patients when they are over the age of 40 or 45. 27% of the patients over the age of 45 and about 21% of those who have older than 65 develop diabetes. So more than 2/3 of patients are going to be older than age 50. So when you talk about management, okay, so most of you are practitioners like me, so you just have to control hyperglycemia. I think that safety is more important than efficacy, so prevention of hypoglycemia is more important than control of hyperglycemia. And you want to prevent complications, right? So again, we talked about this in the previous lectures. I do believe that in the elderly, prevention of hypoglycemia takes a much more important role than lowering hemoglobin A1C. And you have to individualize care. So if you look at the current recommendations have changed, and they're very more flexible now. And most of the recommendations for the geriatric society says to keep the hemoglobin A1C between 7 to 7.5 to the young elderly. So somebody who is doing exercise actively, 60, 65, 70, maybe you can try to push it as much as you can if you can achieve that with no hypoglycemia. For most people, it's going to be between 8 to 9. And for the VA, maybe more than 8.5, they said, should be the way. So you have to individualize treatment according to comorbidity, and more importantly, by history of hypoglycemia. If you have an elderly person with hypoglycemia, not only you should change medication, but perhaps you should change your threshold for hemoglobin A1C. This is the ADA, and we just submitted recommendation for next year for the professional practice committee, and it looks similar to this. For most patients, we want 7.5. So 7 is stretching for a lot of people. So for elderly patients, there is no reason why we should keep it less than 7. 7.5 is good enough if you find elderly and those older than age 65. And here you have what we said for fasting and bedtime. Remember that hemoglobin A1C of 7 is the equivalent of a mean blood sugar somewhere around 150. But hemoglobin A1C in the elderly is not as reliable as in young people. So we want, the ADA is going to say less than 7.5 to everybody, and less than 8.5 those who have multiple comorbidities. There is a new term that we're considering and it's going to be re-emphasized significantly in next year's ADA professional practice standard of care. That is the word overtreatment. And there is evidence right now that we are overtreated many patients, increasing the risk of hypoglycemia. So if you look at this is a population of the VA Medical Center in the United States. And this is the percentage of patients who have hemoglobin A1C between 6.5 to 7. Less than 6.5, even less than 6. So about 40 to 50% of older patients have hemoglobin A1C less than 7. So that's great if you can achieve that with no hypoglycemia. If you accept our definition of less than 7.5 and you go for the elderly, you're talking about that half of the population is overtreated. So there is no need to push that hard because it will increase the risk of hypoglycemia. And there are several papers like this that suggest that hypoglycemia now surpass the ER admissions and visits and hospitalization than hyperglycemia. To your left is hypoglycemia, and in patients over the age of 65 is going up, but the admission for hyperglycemia as a complication is coming down. Again, the word overtreatment is very appealing to us, and we're going to push for that. So how should you treat? And this is what I think, reviewing the literature, and should be the way we should treat. Metformin is the treatment of choice for young and old patients with older patients with diabetes. It works very well. I'll show you some data. And after that, you have to choose an agent that is no hypoglycemia. And I think that DPP4 in the elderly is very appealing. I'll show you some data. Acarbose has been shown in recent studies, especially from China. And the IDEC is going to have a huge presentation of acarbose with cardiovascular safety. So I think acarbose in many populations, and I know you use it in India, is a very attractive agent for patients in the elderly because it's not associated and it has cardiovascular protection that will be shown in the EASD. And then you have the GLP-1 and SGLT2, which is kind of interesting. What is missing in this slide is sulfonylureas. So why not sulfonylureas? Okay. First, let me show you metformin, that it works well in the elderly. Definitely, it works as well as in young adults. And here you have elderly versus non-elderly. Elderly is in the closed circle, non-elderly in the open square. And the reduction in hemoglobin A1C is exactly the same. The GI side effects is exactly the same. However, many studies have shown that metformin has been associated in older people with weight loss. So if you have an elderly person who is losing weight and you don't want them to lose weight, look for metformin therapy in this patient. There is also some evidence that metformin long-term in the elderly is associated with vitamin B12 deficiency, and we're now recommended for you to measure vitamin B12 in long-term patients, especially if they have neuropathy, or maybe in the elderly, check vitamin B12 because deficiency of vitamin B12 is associated with increased risk of falls. An elderly person falls more often than young people. Sulfonylureas is used in about 32% of Americans, but it's associated with hypoglycemia. And it's been associated, especially, but I am aware that sulfonylureas, they're not the same, they're not equal, they're different recommendations. They have the glipizide long-term that is okay, you have glamepiride that can be used in very low doses. If I ever use the sulfonylureas in the elderly, I may tend to use more glamepiride because I can use from 1 milligram, 2 milligrams, and very seldom goes above that. And it's what I have not used in many years, maybe in the last 20 years, we don't even have it in the formulary in our system, is glyburide. So that would be the equivalent to your glyburide, that's right? So glyburide, we don't have it. Why? Because there are multitude of studies suggesting that increase the risk of hypoglycemia, increased risk of falls, and increased mortality. So this is a study that shows in a very large population, 717 patients with type 2 diabetes treated with monotherapy, comparing metformin and glyburide in elderly population. And the risk of death in patients taking glyburide is 3 times more than metformin. So we decided to take it out of the formulary, and we still have glyburide, we still have glipizide that it can be very carefully used in elderly person. But I think of all of the medications that we have in elderly patients, DPP-4 are very efficacious. Here you have how much they reduce hemoglobin A1C, somewhere between 0.6 to 0.8. It doesn't matter which one you use. Even the gliptin that you have it in your country, we don't have it in ours, but of course it works similar in the same way. Durability of this is important, especially in any population. And you have here the durability of hemoglobin A1C with a reduction of about 0.6-0.5% in elderly patients long term. Here you have comparing saxagliptin and glimepiride, and this shows the rate of hypoglycemia for each individual at different age, less or more than 75. And again, sulfonylureas have similar effects on hemoglobin A1C that significantly increase risk of hypoglycemia. This is extremely interesting study published in Lancet a couple of years ago that compares metformin with acaricos. And here you have hemoglobin A1C reduction when to the left, patients with hemoglobin A1C less than 7 to 8, and greater than 8. I have started using acaricos in elderly patients when there is an increased risk of hypoglycemia when I cannot control with just metformin and DPP-4 alone. And it works extremely well in the elderly, and I invite you to use it very carefully, very openly, because it has the same effects in reduction in hemoglobin A1C as metformin. So the IDEC works well. The problem is that it has too many side effects. They have bone loss with increased risk of fractures in postmenopausal females. So just because of that, I stay away from, in addition to the edema, weight gain, and the multiple other products that I'm aware that your country cannot use because of the bladder issues. SGLT2 in the elderly has to be used very carefully, in part because of the kidney function. We are not starting SGLT2 in those patients who has a GFR less than 45. A significant number of elderly persons have a GFR less than 45, and also has the problem with volume contraction in the elderly. And there is an increased risk of fall, as shown by Bill Vilisikian in the JCM paper last year. There's also an increased risk of bone loss in postmenopausal patients in Canada studies. So in the elderly, you're going to be very concerned. The other thing is that the older you get, your prostate gets enlarged in males. And if you have residual volume, there is an increased risk of urinary tract infection just because of the amount of glucose in the urine. So SGLT2 can be used in the elderly? Yes. Is my best friend? No. I've used it very constantly in the elderly, and it's not on my first or second line patient. So, long-term care facility. My group has been working on several randomized control trials now. So the first randomized control trial we published last year, and we said, let's look at the nursing home patients. We have 3 nursing homes, one with the community, poor people, the other university, the other the Veteran Administration Hospital. And we have 150 patients, and we compare oral agents, whatever the doctor wanted to do, to low dose insulin. And here you have the average blood sugar during the 6-month period. And we average them, we measure the blood glucose 3 times a day, and we average things every 2-week period. And what you see here that in the elderly, first, hemoglobin A1C is not too bad. Second, you don't need insulin. And if you ever use insulin, you should use very low doses. We start with 0.1 units per kilo of basal insulin. And this is what's scary. The rate of hypoglycemia when you use oral agents or when you use basal insulin is about 30%. Most of these patients with hypoglycemia were treated with a combination of sulfonylureas and metformin. So, so we just completed this study. I just finished writing yesterday. So it will be submitted very soon. We presented last week at the ADA. And we had patients, this was an ADA grant, and we had patients in the nursing home that were treated with oral agents or low-dose insulin. And those patients that have glucose greater than 180 or hemoglobin A1C greater than 7.5, if they were taking we stopped everything except metformin. So we kept persons in metformin and we randomized to linagliptin or glargine. Linagliptin, you know, it doesn't need to be adjusted for kidney function. So they were taking metformin about 49%, about half of the patients. With linagliptin, half of the patients. Glargine, half of the patients. We have 150 patients. And here is the blood glucose concentration. We followed this patient up to 6 months. And here you have the blood sugar average every 2 months periods, the linagliptin and glargine, with or without metformin. No difference in glucose control. And what you're thinking, I'm sure, the average blood sugar was 150, 146. And here is the rate of hypoglycemia. If you treat patients with glargine, starting at 0.1 units per kilo, so 10, 12 units. The average dose during treatment was 0.15, so somewhere between 12 to 20 units. The average age of this patient was 75, 76. And the rate of hypoglycemia was 7 times greater with the use of glargine compared to linagliptin. We are suggesting that in elderly population, because you cannot predict if they're going to eat or how much they're going to eat, you should use agents not associated with hypoglycemia, such as the combination of DPP-4 and metformin in these patients. This is my last slide. Okay. So in summary, we have 40 seconds. So patients over the age of 65, if you define hypoglycemia, is the largest growing population. 1 out of 3 older people are going to have diabetes. If they are obese, maybe even 40% of them will have diabetes. Target blood glucose has been recommended less than 7. The new ADA recommendation would suggest that most of these patients should be treated with a goal of 7.5. There is not a single study that suggests that keeping the hemoglobin A1C less than 7.5 has a beneficial effects. And these are my last slide, but my recommendation now manage people with diabetes. I would use metformin. My second last agent, according to our studies, is the use of DPP-4 or alpha-glucosidase inhibitors. And these are your friends who are very effective, as effective with metformin. Caution would be the second line, and don't stay away from sulfonylureas in an elderly person unless they have much used it because of cost or access. If you can use those agents not associated with hypoglycemia, you have the same reduction in hemoglobin A1C with lower rates of hypoglycemia. Thank you very much. To answer that question in a scientific way, I believe that in the last 5 years, and now we meet with these guidelines with the ADA every 2 weeks, reviewing all these data. And it's absolutely no randomized control trials in elderly person. There are 2 randomized control trials in our group. There were very small randomized control trials in Europe, and that's it. Exercise in the elderly, very few. I think fitness is very important, right? I mean, in outcome, but unfortunately, especially with diabetes, I don't think has been studied too much in the elderly person, so I don't think we have the data. What I think we are right now in diabetes care, we were on safety. We were first in efficacy. 5 years ago was safety, the main goal, after the Accord trial. I think the future is going to be on cardiovascular program. But in the elderly person, I think we should be extremely gentle in treating these patients. And avoidance of hypoglycemia should be the main way.
Especially the Japanese Diabetes Society, the guidelines on the elderly, they
risk factor for hypoglycemia in the elderly is BMI. So the average BMI in the elderly, if we ever get to be 80, it's not going to be 35, 33. It's going to be about 28. And below 30, especially below 28, the risk of hypoglycemia is markedly increased. That brings a point. If unfortunately, we didn't separate the weight changes in the last 6 months. If you have been losing weight because you are ill, you're very more likely to develop hypoglycemia. But you're extremely correct. The other thing is that in this case, we started to dose very little insulin. And we look for skipping meals. And that's the second risk factor in the elderly nursing home. I mean, it's unpredictable when an older guy is going to eat or do not eat dinner. Just doesn't want to eat dinner, so you get hypoglycemia. Yeah. But weight is, BMI was the #1 risk factor for hypoglycemia. Good.
Do we have the further evaluation of the patients that apart from what is low or like low BMI, do we have other conditions or comorbid conditions which are responsible for increased risk of hypoglycemia?
Yeah.
Or is it just the age? So do we have the adjusted odds ratio calculated through that? That these are the individuals or these are the risk factors. With #1, this is the most important versus #5. Something like this.
So the #1 is weight, BMI. The lower the BMI, very much the risk of hypoglycemia. Renal function was also the second one, as you would expect. When the GFR is less than 45, the risk of hypoglycemia was increased. Third is multiple comorbidities. Otherwise, there was nothing else. There was no significance in race, duration of diabetes, medication that the patient were using before. Nothing else changed.